It is the emerging branch, multidisciplinary branch, because cancer and heart diseases are one of the leading causes of death worldwide. And in fact, in cancer patients, cardiac comorbidities are the raising matter of concern, and they are becoming the leading causes of death after reoccurrence of diseases. I have prepared this presentation under the guidance of Dr. Deepak Puri. So cardio-oncology, it deals with cardiotoxicity. The treatment choices in cancer patients leading to cardiotoxicities. It can be in the form of various heart diseases like hypertension, coronary artery disease, arrhythmias, heart failures, and these cardiotoxicities can be assessed with the help of cardiac imaging. Certain cardiac imaging techniques are ECG, echo, MRIs, CT angiographies, and these cardiotoxicities are managed through multidisciplinary approach, which involves the rehabilitation at various levels, involvement of functional medicine, along with integrated medicine. This is the preventive model for cardio-oncology. It has been noticed and various research has been conducted which show that cardiac and oncologic patients share common risk factors. So it is important to know these risk factors and act accordingly. We need to make certain lifestyle modifications in terms of quitting smoking, drinking less alcohol within the optimum levels. And then we need to have a healthy BMI, cut down on fats, maintain a appropriate cholesterol level. We need to find the family history associated with these cardiac risk factors so that we can assess, so that we can calculate a baseline risk score and plan the treatment modalities accordingly. So we have graded the patients based on the extent of exposure of cardiotoxic drugs. There are mainly two types of cardiotoxic drugs, type 1 and type 2. Type 1 deal with the structural damage and type 2 deal with the functional damage. Prototype of type 1 are the anthracyclines, and cardiotoxicity caused by anthracyclines are relatively irreversible compared to the cardiotoxicities caused by type 2 drugs whose prototype is trastuzumab. So we have divided the patients into categories based on their exposure risk. For example, the patient is on high dose anthracyclines or radiotherapy, or the patient is on low dose anthracyclines with at least 2 or more risk factors, or age is more than 60 years, or the patient is on trastuzumab with these risk factors. The third category would be the patients on low dose anthracyclines plus trastuzumabs. And the fourth category would be the ones which are not exposed to any sort of cardiovascular, cardiotoxic drugs. So after the exposures, we'll look at the symptoms. If the patient presents with no symptoms and has high dose anthracycline exposure or low dose with risk factors, then we refer the patient for cardiopulmonary exercise testing. If the results come out to be positive, then the patient is planned on cardio-oncology rehabilitation. That's the core plan. If the patient has symptoms and certain history of cardiac events, still our plan would remain the same. But if the patient has impairment in physical functioning or speech, and then we'll refer them to their respective rehabilitation programs. That's the onco cancer rehabilitations. And if the patient has none of the exposure, none of the symptoms, they will simply be managed with community-based programs for cancer patients. So this is the way the cardiologist and oncologist integrate to monitor and manage these patients. The oncologist will look at the tumor biology, the choice of cancer treatment. The cardiologist will look at underlying heart diseases, risk factors, baseline cardiac evaluation. And then they will form a risk score. Accordingly, they'll plan a monitoring plan and the treatment guidelines. Baseline risk assessment is primarily on certain aspects like the physician will take the history of the patient, they'll assess the risk factors, they'll do physical examination, and they'll measure the vital signs. Along with that, they'll perform certain complementary tests like BNPs, cardiac troponins, ECGs, kidney functions, lipid profiles, and they'll calculate a baseline risk score. These are certain risk factors which need to be identified. They are broadly classified into two types: patient-related risk factors, medication-related risk factors. Each presence of each patient-related risk factor will conclude to a score of 1, and medication-related risk factors will be according to the subcategory the medicine is belonging to. For example, the medicine is in the high risk category, then a score of 4 will be given. These medicines are anthracyclines or cyclophosphomides. If the medicine is for intermediate, then a risk score of 2 will be given. Examples: docetaxel and sunitinib. Bevacizumab and imatinib will be given a score of 1, and etopside and rituximab have least cardiotoxic effects, so a score of 0 will be given. Patient-related risk factors are heart failure, hypertension, diabetes, prior or concurrent anthracyclines, or any chest infections, age belonging to the extremes, that's less than 15 or more than 65 years, female gender. So we'll calculate the risk score by adding the medication-related and patient-related risk factors. So this is the risk score which we calculated. If a score of more than 6 is calculated, then the patient belongs to very high, 5 to 6 high risk, 3 to 4 intermediate risk, 1 to 2 low risk, 0 very low risk. The significance of calculating this score is that our monitoring plan will be designed based on this risk score. If the patient belongs to very high score, for example, that is the score more than 6, then we'll perform TTE, that's transthoracic echocardiography with chain, at the end of every cycle, and for follow-up purpose, 3 to 6 months and 1 year post chemotherapy. The cardiac troponins will be carried out with every TTE with chain. For high-risk patients, after every 3 cycles, we'll be performing TTE with chain along with cardiotroponin findings, and follow-up will be with the help of TTE at 3 to 6 months or 1 year post chemotherapy. For intermediate risk, we'll perform TTE at midterm, 3 to 6 months after chemo, along with CTNs. And for low and very low, we do not need to perform any monitoring techniques as such. These are the prevention strategies which we use for the patients, the cancer patients who are at the risk of developing cardiac diseases. We'll calculate the baseline CV risk assessment based on the discussion in the previous slides. And if the patient falls into high or very high risk score, then we'll minimize the use of cardiotoxic drugs, and we can use ACE or ARBs and beta blockers as protective drugs. We can use statins, and the patients who are on anthracyclines therapies can be given liposomal anthracyclines. So this is the algorithm for detecting the reduction in ejaculation fraction and planning a treatment plan accordingly. If there is reduction in left ventricular ejection fraction less than 40%, then we'll stop the chemotherapy and start the patient for heart failure therapy and reassess the patient in 30 days. If ejection fraction is between 40 to 50%, then we'll continue with the chemotherapy and we'll start treatment for heart failure. If ejection fraction is more than 50%, we'll continue with the chemo and assess for the symptoms of heart failure. If present, then we can provide the treatment guidelines. This is the graph which shows the significance of using heart failure treatment in patients on anthracycline therapy earlier. If we use the interventions at 1 to 2 months, there was a 64% response to there was a 64% response in case that the patient did not develop the disease or the patient's disease reversed. If the timelines were extended, then the response decreased. In the subsequent graph, we see that the responders had 0% death rate due to heart failure, and they had 3% risk of arrhythmias as compared to non-responders, which had 16% risk of arrhythmias, 8% risk of heart failure, and 4% of deaths according to this non-responder. And this non-responder depended on the time of treatment of initiation of the therapy. So that's why it is important and of vital importance that we assess the risk factors earlier and manage the patients so that they develop lower risk of cardiac comorbidities, and we can provide a good lifestyle to the patients, to the cancer patients. Thank you.